Thanks, Rich. So as Rich said, I'm going to be the pivot to more of long-term care, and by long-term care I mean basically help with activities of daily living like eating, bathing, and dressing, and instrumental activities of daily living like housework and helping with public transportation and managing finances. And in that world, we talk about consumers and participants. We don't talk about patients because it's a much less medicalized, less skilled-oriented kinds of activity, as I'll talk about a little bit later. Many of these people do have serious medical problems, but that's really not what the long-term care part is about. And so we're kind of the flip side of one of the issues that Barb Gage was talking about. She mentioned that in some cases the therapists didn't have enough information to do what they needed to do, but it's in the home and community-based services where the assessment instrument is providing more information than is needed to provide the home and community-based service like personal care because they're not providing the kind of therapy services that are part of our post-acute care setting. So my charge is to try to think broadly about the components of the long-term care system and what are the pieces that need to be identified and solved and put together. And I can't say that I'm going to offer the United States as a model. I don't think there's some things we do well. There are a lot of things we don't do well. There's some things we do terribly. And, but I think it'll be illustrative to talk about some of the struggles that, that we've gone through. And so the four big topics that I want to talk about are how should long-term care be financed, how should it be delivered, what should be the relationship between the healthcare system and the long-term care system, and then finally, how should quality of care be assured? I think that's a very important issue that we really need to focus on. So how should long-term care be financed? So this is probably the area of long-term care that we do the least well. Services are expensive. A year in a nursing home costs $85,000 to $90,000 a year. The vast majority of older people don't have $85,000 to $90,000 a year. Medicare, our government program for health care for older people, does not cover long-term care. It covers a lot of post-acute care, but a short-term post-hospitalization kind of post-acute care. And few people have private long-term care insurance. So what does that mean? That means that people who use long-term care routinely experience catastrophic out-of-pocket costs because they can't afford it. And so what happens? What happens is that they impoverish themselves and they end up with their care paid for by Medicaid, which is our federal, state health and long-term care program that is means tested. It's a welfare program. You only qualify if you're poor or become poor because of the high costs of long-term care or other kinds of health problems. States have a lot of responsibility and authority over the Medicaid program, which means that the programs vary by state, which creates problems of horizontal equity because what you get depends a lot about where you live. We have an institutional bias in financing. Most of the money goes for nursing homes and other kinds of institutions rather than home and community-based services, which is what people want. And then we, like the rest of the world, are aging, and so we're going to spend more. As much as people wring their hands about the amount of money we spend now, we're going to spend a lot more, as I'm sure they will in Taiwan and throughout the world. So private insurance in the U.S. has always been the dream solution. Americans like private insurance, but it really hasn't worked. There's been a pretty active market for about 30 years. About 12% of the older population have some kind of insurance. Many of it has problems. Only about 5% of the 45 and older population has private insurance. And one of the major reasons is that is cost. It's simply not affordable for most people. In 2010, before a lot of the major price increases, the annual cost was, at age 65, was about $2,500 a year. So for a married couple, we're talking $4,000 to $5,000 a year. That's simply too much. And since the recession, the market has come close to collapsing. Basically, most of the private insurers have left the market. Those that have stayed have dramatically, and by dramatically I mean 75 to 100% increases in premiums. So they've dramatically increased the prices, and they've substantially tightened medical underwriting. So you have to be much healthier in order to qualify for benefits, or to qualify to buy policies. So there are a lot of reasons for that, and we can talk about that maybe later. But what it really boils down to is that with low interest rates, insurance companies got a very low rate of return on their reserves, which was not what they were expecting, and so they found themselves losing money rather than making money. So as I've already mentioned, most people get their long-term care through a public program, which is Medicaid, again, a means-tested welfare program, and it pays for about 62% of long-term care expenditures. And states, again, have a lot of authority about what is covered and how providers are paid and so on. And depending on your perspective, that's either great or creates a big problem. It means that if you think it's great that there's this wide range of how things are done, it's because states are responding to the particular needs in their communities and their areas, and there's not a single solution being put forth by the central government. If you're concerned about horizontal equity, again, about the same people not getting the same sets of services, then the current Medicaid structure is a real problem. Conservatives in the United States very concerned about the level of government spending, especially for the Medicaid program, have argued that we really need to substantially constrain expenditures, either by capping the program and not increasing it as fast as it has been increasing it, or tightening the Medicaid financial eligibility so that fewer people will financially qualify. Liberals have not paid that much attention to the Medicaid program because they've been more interested in public insurance, but to the extent that they have focused on it, they've tried to protect Medicaid in its current form and have argued for some liberalization of financial eligibility and giving states more options for home and community-based services. So by a kind of process of elimination, we kind of end up with public insurance, with this notion that there's a collective responsibility for long-term care rather than an individual responsibility. The failures of the private sector and means-tested programs to solve the problems sort of means that there's no other way to address it. And people who advocate public insurance have argued that there's no fundamental reason why we should treat long-term care differently than acute care, although we do. Obviously, in many parts of the world, there are these mandatory public long-term care insurance programs paid for through a combination of taxes and premiums. There's public insurance in the Netherlands, Germany, Japan, soon to be in Taiwan, and non-means tested programs in Scandinavia. So the issue here in the United States is that it all comes down to what is the role of government. And you don't have to pay very much attention to the US to know that we are very, very deeply divided on the question of what is the role of government in healthcare and long-term care. You name the topic, we're deeply and fundamentally divided about it. And so the question is, where do things fit on the continuum between long-term care is an individual responsibility and at the one end, and on the other end, long-term care is a social responsibility. We're all in it together, and it's a collective responsibility. So how should long-term care be delivered? So in the United States, like many of the developed countries, long-term care basically started as an institutional set of services. And as the system has developed, we have recognized that that wasn't the optimal kind of system, that the kind of services that people want is home and community-based services. People want to stay in the community. And then it's also argued that the quality is better. Maybe that's the case, although we don't have evidence about that. And maybe we save some money by having a more balanced system, although the research evidence is not particularly strong for that. And so what we have now is a very, very broad, bipartisan, cross-ideological consensus to change the long-term care system from one being fundamentally institutional to being a broad range of institutional and home and community-based services. What's the optimal percentage? Well, we really haven't got a clue. We don't have any measures for that. There is a very broad range across the states, from some states like Oregon and Washington, where in excess of 50% of Medicaid expenditures are for home and community-based services, and we still have some states like Mississippi, where the vast majority of spending is for institutional care. So this chart shows what has been happening to nursing home use, and I show this for two reasons. One, to just show the declining use rates. So the green is the increase in the population age 85 and older between 1990 and 2010. And as you can see, it's kind of roughly doubled, but the number of people in nursing homes has basically not changed a whit. It hasn't changed at all. And that means that the use rate has fallen dramatically. So I also show that graph also to emphasize that demography is not necessarily destiny, and that the world is a lot more complicated. And just because you have a big increase in the 85 and older population doesn't necessarily mean that you're going to have a huge increase in your institutional care. So this slide shows the proportion of Medicaid long-term care expenditures for the elderly and disabled population for Medicaid that goes to home and community-based services. And as you can see, over time it's gone up substantially. By 2010, it hit about 36%. It's now about 40%. So part of the story is that we've moved towards more home and community-based services, but we've also tried to change the paradigm in which the home and community-based services are provided. And I want to talk about four factors in this change in the way in which we've conceptualized home and community-based services. The first has to do with aging and disability resource centers that Lisa Alexi will be talking about. The second is consumer direction that Kevin Mahoney will be talking about. Money follows the person demonstration. And finally, residential care facilities and assisted living. So we've built a pretty complicated financing system. In addition to Medicare and Medicaid, and out-of-pocket spending, we have a whole bunch of small state-funded and federally funded programs that provide home and community-based services. So it's an extremely fragmented and disorganized system. And so the question is, what does the poor consumer do who finds that they need these services and is trying to find some financial support? And so the federal government has provided funding to the states to develop so-called aging and disability resource centers that are meant to be a single point of access to the long-term care system. Consumer direction. So historically, home and community-based services have been provided by agencies, but agencies have not necessarily provided the services that people have wanted. They've been inflexible. Some people don't want strangers coming in to give them baths or helping them go to the toilet. And some people would just prefer that they have a bigger role in terms of directing and arranging their services. And so under consumer direction, the individual consumers are able to hire, fire, direct, train, schedule the workers. And so this movement or this direction came out of the younger people with disabilities movement, but has been applied broadly across ages and different types of disabilities. So who do people generally choose when they're given a choice of workers? They often choose family members, and so we get into some difficult questions about paying family caregivers and the role of the government and what is the role of informal caregivers. States and Medicaid programs typically pay much less for this kind of consumer-directed care than they pay agencies, which is partly a cost-saving strategy on their part, although that's not the major thing that they're trying to accomplish. But even that is more complicated because if there are agency shortages, but not shortages on consumer direction, then total expenditures can be greater than if you had stuck with a purely agency-directed system. So much of what we tried to do in the United States over the last 30 years in terms of trying to reduce use of institutions has really been at the beginning of people, or trying to prevent people from going into nursing homes at the beginning, to try to divert them away from the institution at the point of admission. What the money follows the person demonstration does is it kind of turns that on its head and says, let's go into nursing homes and other institutions and identify people who can live in the community and move them out. Let's kind of undo some of the mistakes or problems that we've created by having an overly institutional biased system. And so the federal government is sponsoring a very large demonstration to do this with very strong financial incentives to the states to do it. The bottom line so far, and the demonstration is still underway, but the bottom line so far is that it's quite hard to do this. Once people have gotten into institutions, it's hard and given up many of their community contacts, it's hard to move them out. And it's especially hard to find housing for this population. So the final area I wanted to talk about in terms of the delivery system is what we call, under a variety of different names, residential care facilities and assisted living. So these are physical locations. They're residences that provide room and board, 24-hour supervision generally help with activities of daily living, and some help with health-related activities like medication management. And so for people like people with Alzheimer's disease who don't, at least at the beginning, need lots of hands-on care but a lot of supervision, this can be a very attractive kind of approach. And the costs are much less than nursing homes, so it has that kind of popular appeal. Medicaid pays for some of it, but most people in assisted living and residential care facilities are paying privately. So the two big issues that come up with this is, so what are these things? Are these really institutions? And in the counting systems of many other countries that have similar programs, they count them as institutions. Or are these home and community-based services because they are less medicalized and provide more consumer choice than does the overwhelming number of nursing homes? And similarly, from a kind of regulatory quality perspective, to the extent that these facilities allow people to age in place, is that great? Is that really good? Or is it that they are now caring for very severely disabled people, and what they really are unlicensed nursing homes? So an important part of our long-term care system, and one that we haven't really quite figured out, but in some of the states that have a very high percentage of their spending on home and community-based services, like Wisconsin, Oregon, Washington, these kinds of facilities play a very important role. So the third question is, what should be the relationship between health care and long-term care? So like most developed countries, or virtually all developed countries, we have a fragmented system with long-term care over here and acute care over here, and they speak different languages and they have different reimbursements, and they don't work well together at all. So the problem is that in the real world, individuals don't come with just acute care needs or just long-term care needs. They come with some combination of it. They're not necessarily all patients. They're not all people with heavy medical needs, but they're not all, but many people have many medical needs who also need long-term care. And so this is very much the focus of the federal government right now, of trying to find ways to bring acute and long-term care together with the basic hypothesis that if we can better integrate the system, then we can provide better care and lower costs. And speaking as a long-term care person, one of my fervent hopes is that we can get savings on the acute care side, on the medical care side, that we can then use to finance expansions of long-term care services, especially home and community-based services. So what this chart shows is Medicare spending per enrollee age 65 and older by their functional limitations. And starting on the left are people with no problems with activities of daily living. They have about $4,300 in annual expenditures. If you go to the far right with people with 3 or more activities of daily living, their expenditures are nearly $19,000 a year. So there's no doubt that the people with long-term care needs, that is the people who have problems with the activities of daily living, have on average much higher acute care expenditures. And so there is some hope there that maybe we can get some savings there that we could use to either flatten the overall growth in healthcare spending, or at least use that to help finance long-term care. And here's another slide. There's been a lot of research, some of which I've participated in, that have looked at so-called potentially avoidable hospitalizations, hospitalizations that might have been prevented with good quality care. Especially, there's been a lot of research in nursing homes. So looking at the chart, you pick your study somewhere between about a quarter and 2/3 of hospitalizations by people in nursing homes might have been prevented if better quality care had been supplied in the nursing home. So, as I said, the Centers for Medicare and Medicaid Services is in the process of conducting a very large-scale demonstration that tries to integrate Medicare and Medicaid, basically acute care and long-term care. 13 states are currently participating, more are coming down the road, and these are many of the very large states, so we're talking about a significant portion of the population that is eligible for both Medicare and Medicaid. And the way this integration is mostly going to take place is by making per capita, per person payments to managed care organizations who will be responsible for both the health care and the long-term care of this population. So there are a variety of issues that come up with this. Will it, obviously, well, let me say first, RTI, where I work, has the evaluation contract to look at this evaluation and to try to figure out what the effects are. But it's going to be several years before we get any clear quantitative results. So will it save money? Will it improve care? Will people receive the services they need? In any sort of capitated setting, the organization makes money by spending less than what they get. So one way to spend less is to provide less in the way of services. So that is an issue that needs to be addressed. Will this combination of medical care and long-term care over-medicalize long-term care? As I said at the very beginning, long-term care is really much more about how we live our lives and about non-medical kinds of services. And if you put them in a setting where hospitals and physicians dominate, there is a risk that these consumers are going to become patients and their voice is going to get lost. And finally, will people lose their choice of providers? One of the things that managed care organizations typically do is they limit the number of providers that participate, and so there is a potential for some providers being left out. There's some potential that or some question about how the managed care organizations will select the providers. So a number of issues of that nature. So, Rich, do I have time for one more, or should I? Okay. So the final thing final issue is quality of care in long-term care. So this is one of the areas we also do least well. Quality of care is a very long-standing, if sporadic, policy and media concern. I got involved with long-term care in 1975 as part of a state commission in New York that was investigating quality of care scandals in nursing homes there. And depending on your measure, somewhere between a quarter and a third of nursing homes have been cited for poor quality care. As I mentioned earlier, there is popular belief, and I would go with it, that home and community-based services provide higher quality care, but the reality is we don't have much in the way of actual data and to assess that one way or the other, and we certainly don't have any data to assess individual providers. So I think it's important to kind of go to first principles to think about, so why is this a problem? Partly it's a problem because the population at need is very vulnerable and disabled and often cognitively impaired, and they don't necessarily have people there to advocate and to fight for them. With some people who have cognitive impairments, Alzheimer's disease, they are combative and aggressive, so they're sort of difficult people to work with. It's not all, as we say, a walk in the park. Serving this population is difficult. Providers are often understaffed, and the staff often have little training. Robin Stone will be talking about some of those issues. The public reimbursement, three-quarters of residents in nursing homes in the U.S. are paid for by either Medicare or Medicaid. So the government really is deciding the amount of money that is available, and in some cases, in some states, I think an argument can be made that the reimbursement is not adequate, and you, to some extent, you get what you pay for. And finally, depending on the service, there can be a shortage of providers that means that there's not an alternative to go to. You may not be happy with the quality, but there's no place else to go. So nursing homes are heavily regulated, heavily inspected. We do more inspections than any other country on earth, but we still have the problems that I was talking about before. There are issues about the subjectivity and variation in the application of the rules. The industry complains that we're not measuring quality, we're measuring paper compliance. Consumers argue that there's not strict enough enforcement, and there are a variety of other issues as well. So in addition to regulation, we've looked to a number of other approaches, two of which are most important, or three are most important. One is that we have developed through the minimum data set, the MDS, we've developed a number of quality measures of care in nursing homes, and we've posted them on the internet, and the research shows that that has had a modest impact on improving quality of care, not a dramatic impact, but a modest impact. And we have experimented with pay for performance. Congress recently passed a law saying that for Medicare skilled nursing facilities, there will be a pay for performance program, but it's very narrow. And the reality is that the research on this area has, at least for the nursing home area, been uncertain, to say the least, in terms of its effectiveness. And then the third area is culture change, to try to change the way in which the workers participate in their job, to try to give them, to try to empower them more to participate in the overall planning and delivery of services, and to do so in more home-like settings. As I said, Robin will be talking a lot more about that. Our regulatory system is really focused on institutions. Like most of the rest of the world, we really don't do much about home care in terms of regulation. There isn't much in the way of standards at the state level, and there certainly is nothing comparable to placing the quality measures up on the internet like there is on nursing homes. So I think a lot, again going back to what Robin's going to be talking about, a lot ultimately will come down to the workers. Long-term care is not a widget. Long-term care is a service that are provided by humans to humans. And one of the major problems that we're going to have in this country is a diminishing supply relative to the demand. So this is the ratio of the number of persons aged 20 to 64, basically the working population, to each person age 85 and older, roughly the population in need of long-term care. And as you can see, that line just goes down. I mean, just a 45-degree angle downward as we approach 2050 from now. So the question is, how are we going to get the population in the United States and in Taiwan to actually provide the services that are needed? There's a chance of technological breakthroughs, but you know, I'm not sure I want to be fed by a robot, that's really, I think, the fundamental issue. So in conclusion, again, the United States offers some lessons, even if it doesn't offer necessarily a model. I think one major takeaway, which I think Taiwan has recognized, is that throughout the developed world, it's really the public sector that is the overwhelming source of financing for formal long-term care services. People can hope for a supplementary role for private insurance and other private sector things, but in no country does it really play a major role. It would be best if Taiwan did not start off with a overly institutionalized delivery system, which they then would have to undo. It would be better to start with a balanced system to start with. How to create an integrated medical care and long-term care system is difficult, and it's not clear what the path is to do that. In the US, we're putting all of our eggs into some kind of managed care setting that give a single entity financial responsibility for both the medical care and the long-term care. How that's going to work out, come back in 5 or 6 years and we'll tell you. Quality of care is a problem, much more than I think in the medical care system, and that I think goes back to the fact that we're not talking about cures, we're not talking about rehabilitation, we're trying to provide the services with a population that is low paid and doesn't have much in the way of training. And so finally, I tip my hat to the ministry from Taiwan. It's extremely exciting to try to put together a long-term care system from scratch. And looking at your long-term demographics, they are much more daunting than they are in the United States, with a much higher percentage of the population that's going to be elderly. We in the United States have done our best to hide from making these decisions at a much lower predicted percentage of the population that will be elderly. And so that you are moving forward and actually meeting those challenges, I think is a great tribute to you. Thank you.
Hello, I'm a practicing geriatrician in Taiwan, so I sometimes notice the quality of medical practice in long-term care settings. So I'm very curious, if you're running an independent long-term care system, which is not very much linked to the medical care system, how are you going to assure the medical practice, the quality of the medical practice in the long-term care setting? On the other hand, during your inspection of those long-term care facilities, how many of these quality indicators will be medical, as well as the chronic condition management? The quality of the chronic condition management in the long-term care setting, how are you going to evaluate the quality? And especially this long-term care system is not very much linked to the medical system.
So we have a fragmented system, and so we don't do a good job of bringing together the medical component for people who need long-term care services, and that's why we have great hope for this integrated system, because we'll have a single organization that will be responsible for both. One of the problems we face in managed care organizations is because we're making a monthly payment rather than getting a bill for every service we provide, or they provide, we get much less information from managed care organizations about what they're doing and how they're doing it. Now, the government's trying in these demonstrations to require reporting on encounters, but getting providers to report on encounters that they aren't being paid for is difficult. So I think that's still a work in progress, and we'll have to see how that turns out. And so for home and community-based services, as I said, we really don't have much in the way of quality measures. Some states have done essentially satisfaction surveys that kind of get at the system level, but nobody is really talking about producing quality measures at the individual provider level. On nursing homes, we have quality measures upon quality measures. We have, if you go to the Nursing Home Compare website, there are 16 or 17 quality measures that are available, and RTI has another contract with CMS to develop more measures. So I guess the last thing I would say is part of what's important is to develop the quality measures, but the other part is, what do you do with the quality measures? How do you do enforcement? How do you motivate providers to make the changes to improve? And I think that's another area where I think we in the United States could do with some improvement, trying to use all the information that we currently have in a more fruitful fashion.
Dr. Wiener, congratulations and thankful for your very specific and you point out the need of the U.S. I'm concerned about is the population increase with the Medicaid increase eventually, and this is going to be the private sector, the return of investment is reduced, nobody's going to invest it. End up to be all governmental program, and that in turn will influence the quality care of the long-term care. I have several houses providing for medical special need facility, actually working pretty well. Those people in the community which like medical need, like multiple sclerosis, deafness, and hearing and blindness, or veterans. Those are people, active people, can be working community. They don't have to be in institution. Those are outside, provide the housing for one-step services. That working pretty well. I've been providing for two counties in this area. That sounds could be in the problem because could be an issue when we can save some money. In consider the population and the Medicare and the quality reduction. We got to do something with Obamacare. They're going to be everybody eat or you can eat mentality. As you have pointed out, once they're in the program, they don't want to get out of it. They want to get share on that. So how would you perspective, again, is the Obamacare that I have physician and provide, outpatient, the locum tenens, I can see the difference. People have the complete care, just eat all you can eat. They want everything. So how do you deal with that issue?
Well, the first thing I'd say is that Obamacare does very little in long-term care. So that was, it had one major provision, which was a voluntary public long-term care insurance program that basically was never implemented because the actuaries decided that the risk of adverse selection was so great that it wouldn't be financially stable. So what Obamacare basically offers in terms of long-term care is a number of options for states to expand home and community-based services, and it did set up, sort of set in motion the kinds of demonstrations I talked about in terms of the integration. But I think, and it certainly provided an impetus for a lot of demonstrations to try to better coordinate care for people with chronic illnesses who are Medicare beneficiaries. So I guess my first response is, if there is a problem with Obamacare, it's not because they're doing too much on long-term care. That was an issue that was largely left out. In terms of the kind of the role of long-term care in Medicaid, the proportion of Medicaid going for long-term care has dropped substantially over the last 20 years. Most of the expenditures are for acute care. That part is what is growing. And if you really want to know what's driving the Medicaid budget, at least to this point, it's acute care expenditures for younger people with disabilities. That's really the driver, and something that has gotten almost no attention.
Harvey Stearns from the University of Akron. How do you factor in this rural versus urban service delivery issue that we talked about earlier today in your thinking?
Well, mostly I don't think about urban versus rural, but obviously in rural areas there are fewer providers, less in the way of services, and I think that's where we're going to have to depend more on informal caregivers and some of the kind of less, and we may end up paying them through consumer direction, and also trying to build on some of the more social infrastructure things like churches and Kiwanis clubs or whatever. And so, I think rural areas are important, but the reality is the vast majority of people don't live in rural areas. The vast majority of people live in metropolitan areas.
I'm sorry, kudos to the Taiwanese delegate, because I've been in the state for 40 years. I'm dealing with rehab in the United States, so I do take care of a lot of chronic illness. And what Dr. Yu is saying, that it's true, even within small community, there are some home unit that's given, provided for the disabled body, and then just have home care come to the house. I think that's a great idea. And I think Taiwan should take that up. And I know in Taiwan they already have it. Like a lot of time we do have home care, because I think a lot of family members hire their own people to help, and if they're very poor, the government can do some subsidizing. I think that's a gradual way to get into a long-term care, rather than run into it rapidly, because you're going to go into a disaster if you do that. And the other quick comment about people from Taiwan need to know, in order to qualify Medicaid, you have to run out of all your money. So for people to stay on the Medicaid supported facility, you have to run out all your savings and money, and then the government will subsidize it. So in Taiwan, that's not a very practical thing. So I think people need to be aware of it. Thank you.
Well, I don't know why I'd be interested to know why it's not practical there where it's practical here. But so just to explicate a little bit on that. So if you're a single individual in a nursing home in the US, you can have about $2,000 in financial assets, and you have to contribute all of your income towards the cost of care, except for about $40 or $50 a month. So not quite enough to get a Starbucks coffee every day, but that's about it. The one major exception is that by and large, the house is not a counted asset. So there are not many, but there are some people on Medicaid who do have a house, and that house may be worth a fair amount of money. And again, one of the things that the conservatives would like to do with Medicaid is to make the financial eligibility stricter by counting the house or other things that would count personal effects like your car or your furnishings in your house, and if you have too much, say that you're ineligible.